Today is the start of No Shave November. All month, men will put away their razors to support awareness of men's health issues such as prostate cancer. Early detection can be key to treating prostate cancer. Christina Butler is here now with a look at how new MRI techniques are saving lives. Christina.
Hi, Amy. Russell Waldborn's cancer was mid-level aggressive. It could have been missed if it was not for a new type of testing. Here is his story.
Eddie, come here. Eddie.
It's been an unexpected 7 months for Russell Waldborn and his wife, Cindy. In April, a routine day of taking care of their 6 dogs and a general physician's checkup found symptoms of prostate cancer.
I just told him, when I go to the bathroom, for lack of better words, I dribble. And he says, well, we better check.
His PSA levels confirmed it.
I've seen people with cancer, and it really is not a good thing. They're really sick, and I wasn't really sick. The operation made me sick, but the cancer didn't make me sick because I really didn't know I had it.
The next step, a biopsy. It included MRIs. Dr. Jay Rahman explains.
In his case, what we found was he had an area on the prostate that is on the top side, or the anterior side of the prostate. Only about 15% of prostate cancer is located on the top side of the prostate. And in fact, during normal biopsy procedures, we don't sample that routinely. So the MRI was critical to show us that the area of his cancer was likely going to be at an anatomic portion that was not normally sampled. And now we have the power to do what's called an MRI fusion biopsy. So we take that MRI picture, and at the time we do an ultrasound biopsy, we take that MRI picture and superimpose it right on top of the ultrasound. And that way we can make sure that at the time we're doing the biopsy, we sample that area. And in his case, that happened to be the only area that he had prostate cancer.
With the cancer pinpointed, it was time to decide between surgery or a radiation chemo treatment. Here, Cindy's experience as department coordinator of surgery at Penn State Health came in.
Cancer is a scary disease, but coming from my background of surgery, the idea of removing the problem, I would hope would remove the issue. So I obviously was very proactive towards surgery.
If they do chemotherapy and radiation, it destroys a lot of the tissue around there that they won't be able to take it out then, Where this way, with it being encapsulated in the prostate, he could just, surgically remove it and I should be pretty clean. That's what they were hoping for.
As Dr. Rahman drew out their options, Russell told him about his upcoming plans for a mission trip and a vacation out west.
He says, go and enjoy your summer, enjoy your vacation. I think you'll be fine, and we'll schedule it as soon as you come back. So we got back from vacation, but the surgery was very, very easy.
Russell is now recovered, able to plan more trips and keep up with his dogs. In 7 months, he's been diagnosed, treated, and recovered from cancer, all thanks to new biopsy options.
In his case, he had a more aggressive type of cancer. And one of the things that can happen is if a patient like him is misdiagnosed, we don't detect that area on the top side of the prostate, and he goes 1, 2, maybe 3 years where that cancer is growing and we have not picked it up, then the issue is he going to be curable? Is this going to potentially spread? So it's allowing us to make a diagnosis at an earlier stage. I'm fairly certain Russell will have a very good outcome.
I still don't understand that I had cancer. I don't really know what cancer is, and apparently it's out, it's gone.
Russell did say the recovery from surgery was rough, but he says it was certainly worth it. He will continue to have routine checks. Amy, back to you.
Thank you, Christina. Joining us now is urologist Dr. Jay Rahman. Now, as we saw in that story, Russell was diagnosed with a more aggressive type of prostate cancer, yet showed very minimal symptoms. So can you talk more about how screening works?
Yeah, I think you hit on the important point. Most men with prostate cancer actually have minimal to no symptoms, and so screening is critical here. It's really responsible for us to pick up cancers that may be early stage, that are not only treatable, but hopefully curable. And prostate cancer screening is really simple. It involves a blood test called PSA and a rectal exam to feel the prostate for any lumps or bumps or abnormalities. And if either of these two are abnormal, it should at least prompt a discussion about the merits of prostate cancer screening and maybe even the role of a biopsy.
It's a little bit scary to me that the majority of men won't have symptoms. So again, it stresses how important that screening is. Are there national guidelines in terms of screening, management, treatment?
Yeah, I think one of the most common misconceptions is that prostate cancer is one uniform or homogeneous entity. But in fact, there's a whole spectrum. If you look at the 160,000 men diagnosed annually in the United States, you have a large percentage that are low risk, intermediate risk, and some that are high risk. And our national guidelines advocate for us to treat them differently. A low-risk patient may be appropriate for surveillance. A high-risk patient probably needs more treatment and therapy. And one of the critical things in assigning risk is prostate biopsy, and that helps us know what type of cancer we're dealing with, and that's why refinements and improvements in technology are critical here.
We mentioned biopsy, but in that story we heard that Russell talked about the MRI fusion biopsy. How is it different? How is it potentially better than a traditional biopsy?
Sure. So a regular biopsy, an ultrasound biopsy, involves putting an ultrasound probe in the rectum, visualizing the prostate, and taking a template of different areas within the prostate. The problem is we may miss some areas of cancer, so there's an inaccuracy that may be associated. The beauty of the MRI fusion biopsy is it takes an MRI, which has outstanding visualization of the prostate, superimposes those pictures on the ultrasound while we're doing the procedure, and allows us not only to target all of the normal areas, but those high-risk areas that are more likely to have cancer.
So in terms of how have the results been so far?
So, I don't think any guy is really that excited about having a prostate biopsy, but when we do this, they want to make sure that we get the information that we need. And that's what we found, that MRI-guided fusion biopsy allows us to more accurately pick up cancers in men, but more importantly, pick up the cancers that likely require treatment.
Very good. Knowledge is power, right?
Absolutely.
Knowing what you're dealing with. Thank you so much, Dr. Rahman. We're going to be back with you in just a few moments. But as part of the special Good Day PA, ABC 27 and Penn State Health are hosting a web chat. Deborah Pinkerton is here now to share some viewer questions. Hey, Deborah.
Hi, Amy. Specialists are answering your questions right now at abc27.com/prostate chat. Joining us right now is urologist Dr. Matthew Cake. Thank you for being here. Here is a question that came in earlier. My husband's PSA was a little elevated a few months ago. Last week he was diagnosed with bladder cancer. Are bladder cancer and prostate cancer related? Could the bladder cancer be the reason his PSA was not normal?
So both of these cancers occur in older men, and so we do see them occurring simultaneously somewhat frequently, but they're not actually linked in terms of any kind of causation. So prostate cancer and bladder cancer don't cause each other. The PSA can be elevated for any number of reasons. Prostate cancer is the one that we hear about most of the time, but anything that stimulates the prostate or irritates the prostate can also cause that PSA number to go up. And so in this case, that bladder cancer, depending on its location, could be stimulating the prostate to produce more PSA. It's probably reasonable to treat that bladder cancer and then recheck the PSA, but that really depends on all of the other things that kind of surround that patient's clinical picture.
Okay, Dr. K, we'll check back with you in a few minutes. And if you have a question at home and you would like to join the web chat, go to abc27.com/prostate chat. Back to you, Amy.
Thank you, Deborah. We'll check back with you in just a bit, but coming up, Jeffrey Thompson showed no signs of prostate cancer. You'll find out how it was discovered when the special Good Day PA continues on ABC 27.